Good afternoon, everyone. This is Victoria speaking. I think we can get started now for our webinar. So thank you to everyone who is attending today's webinar. Today we have the North York Family Health team joining us, speaking on their smoking cessation program. Before we get started, we're going to go through a few housekeeping items. So if you're interested in obtaining a letter of completion for today's webinar, please make sure that you've registered prior to this event now, and then also completed the pre-learning assessment. And in addition to that, signing in to view the webinar in its entirety, and make sure that you've signed in using your first and last name. And finally, after the webinar is completed, I will be sending out a link for the post-learning assessment tomorrow, which you will have 1 week to complete. All 3 items are required to be able to receive a letter of completion. The webinar today also will be live tweeted on Twitter, and you can follow us at PSQuitSmoking and use the hashtag #TeachWebinar to post or read any of the questions. So our speakers today are Christine, Eric, and Rita, who are full-time clinical pharmacists at the North York Family Health Team. They're all TEACH certified and also are also certified for the Certified Respiratory Educators. They have no disclosures or conflicts of interest to disclose. And also, please remember that the content of the TEACH educational rounds are centered on evidence-based guidelines from the following sources. These materials, as well as the verbal presentation and any discussion, set out only general principles, and they do not replace the need for clinical assessments or treatment plans by healthcare professionals. Before I hand it off to our presenters today, I would just like to orient all of our attendees and let them know that our webinar is being presented for the second time using a new platform. So please bear with us if we have any technical difficulties today. If you have difficulty hearing or seeing the correct slides, please let us know in the chat box. To use the chat box, you can see a small chat icon at the bottom of your screen, or it should be on the right-hand side panel of the WebEx window. Please make sure when you're sending a chat message to send to all participants so that all presenters and attendees can view your question. I think that's it for us today. I'm just going to hand it off to our presenter, Christine, who is going to start us.
Hi there, thank you. Thank you, Teach, for having us, and thank you, everyone, for joining us today. We're going to spend the next little while describing how we implemented our smoking cessation program at our family health team. We'll also discuss how we linked our smoking cessation and our lung health program together. And then we'll share some clinical pearls and quality improvement initiatives that we went through with our smoking cessation program. So just to start off and give everyone a little bit of background, we are a very large organization consisting of over 100,000 active patients. We have over 90 practicing family physicians. We've been fortunate enough to have consultant specialists, so other physicians. We have a cardiologist, an endocrinologist, an obesity specialist, a psychiatrist, and a respirologist. Some of these individuals see patients one-on-one, others help with some of our group programming, and others are consultants that we can access on a case-by-case basis. We also have a very large interdisciplinary team that consists of nurses, social workers, dietitians, pharmacists, nurse practitioners. We have a physician assistant, a case worker, a chiropodist, and youth and child worker. And then we have our administrative team that helps support all of our programs and services. So we have a receptionist, a clinical manager, a data manager, a QI specialist, a medical director, and executive director. And as we go through the slides, I'll highlight the various roles that these individuals have in our program. So we have 18 different physician offices that are at 10 different geographical sites. We our covered area is about along the West Bathurst all the way to the Don Valley, north from Steele down to Lawrence. And so we have 10 physician office sites and one centralized site where most of our interdisciplinary team work. It's at York Mills and Don Mills. Our RNs, so our nurses, are embedded in the physician offices, while most of our IHPs are centralized with some off-site services. So we started our program back in 2011, and at this time we had 1 nurse practitioner, 2 pharmacists, and 3 nurses that were interested in smoking cessation. And so they underwent TEACH training, and we got started with the STOP program, and we started our smoking cessation program. At this time, we were providing services mainly at the central site, but also at a few of the physician sites. And then over time, we decided that we wanted to expand our program and train more of our interdisciplinary health teams. And so most of this is we expanded to nurses and physician assistants. So in 2014, we started to offer more training for individuals interested in smoking cessation. And what it looks like today in 2020, all of our physician sites offer smoking cessation counseling as well. They're all stop sites, so they can offer nicotine replacement therapy. We have 24 active smoking cessation counselors right now, so mostly nurses and pharmacists and physician assistants. And over time, we've trained over 50 staff to be able to carry out and deliver smoking cessation counseling. What our program looks like now, too, is that all new staff get onboard training for smoking cessation. They're also asked to complete a smoking cessation course or certificate, such as TEACH, or the Fundamentals of Tobacco Interventions, or the RNAO module for smoking cessation. And then once comfortable, they can deliver smoking cessation counseling, and then as well as dispense energy from stop. We did at one point explore the Ottawa model for smoking cessation. Due to a number of reasons, we didn't pursue this. Mainly, we have 18 different offices, and it was difficult to implement procedures and policies at all of these offices. Some of them were smaller and had limited resources and just had small capacity. So we felt that the decentralized model of smoking cessation was best for our team. So most of our referrals come from our physicians. We are a closed program, meaning that we only see patients that are whose family physician is within our family health team. There's one exception. We have an NP-led cancer survivorship program at our FIT, and we do accept patients from this program. But what usually happens is patients who are motivated or ready to quit are referred to one of our counselors. So they get paired up with a pharmacist or nurse or a physician assistant. We keep the same practitioner for them just to ensure good patient rapport. And then they see us for an initial in-person encounter. During this visit, we'll do an assessment and then offer smoking cessation aids such as NRT, Zyban, and then do counseling. And so at the bottom of this column, you'll see that we also do a COPD screen with a Canadian lung health test, and we'll go into more detail about this, but this is how we've linked up our lung health program with the smoking cessation program. And then some patients who are positive will get, we refer to our spirometry, in-house spirometry, And then otherwise, they'll skip to the smoking cessation follow-up. And we see patients, depending on their needs, mostly once a month, but sometimes every 2 weeks, depending on the patient and their needs. We also practice in a team-based setting, so patients can be referred to a social worker, a dietitian, or an addictions counselor as needed. And then this last column just shows what we track. And some patients are still actively seeing their counselors well into 6 months and sometimes at 12 months. But we always make sure that we check in at 6 months and 12 months for outcome measures and also to see how everyone is doing. So this is a snapshot of what our referrals look like. And as you can see, so when we first started out the program with about 5 practitioners in 2012, there were almost 30 patients. In 2013 was when we had more interested practitioners, and we started to expand a little bit. And then in 2014-15 is when we officially decentralized, and we had offices, or each office trained, personnel trained. And you can see that we see about more than 100 patients each year. We are missing data from 2014, and that was just due to a transition in the way we captured our stats, and we moved from an electronic system, so we're missing data for that year. But we sort of reached a plateau, and we would expect it to just kind of be maintained at this level for new patients that are referred to the smoking cessation program. So I'm just gonna, this is our, a little bit of demographics and our age. And so most people we see are about middle-aged, but you can also see, we do see some young people under the age of 30. And then once in a while, we'll get a referral for someone on the other end of the spectrum, or older adults over 90. The primary treatment is NRT, and we are fortunate again to be involved with the STOP study. But we also do a handful of Champix-Zyban and combination therapy as well. This is an example of what our medical directive looks like. Similar to probably other programs that are involved with STOP and dispense NRT. It covers our physician assistants and our nurses for dispensing nicotine replacement therapy. And our medical director is the one who signs off on this each year. So she supports this initiative and oversees the dispensing done by practitioners. Our pharmacists and NP practice within their scope, so they're not officially covered under this medical directive. On the other side is just the essentially the STOP algorithm, and it provides a little bit of guidance for the nurses to start NRT at what doses, and some information about how to titrate up and so forth. At our family health team, we document under 2 electronic medical records. So we use Acuro and TSS. We've developed some really good templates that we use. And so we have an initial template and follow-up templates for documentation purposes. As well, we use these templates to track our 6-month and 12-month outcomes. So this is what a sample of what our initial visit template looks like. It looks long, but it gets collapsed a little bit as you kind of go through the template. And so this is it's a suggested guide for practitioners who are conducting an initial visit. And it starts with history. And so we gather, the age of when the patient started smoking and how many cigarettes they're smoking now versus before. Again, we've built in our Canadian lung health test right here. And so this will segue to the lung health program if they're positive. Then we encourage a Fagerstrom assessment for nicotine dependence. And then it allows for prompts for more history gathering. And so it assesses previous quit attempts, triggers, environment, reasons for quitting, as well as other substance use, so any alcohol, caffeine, or recreational drug use. We also have the readiness ruler in here. So the scales from 1 to 10 for importance and confidence. And then we do encourage patients to set a quit date. And so that's here, as well as their reason for wanting to quit. And then some other points for assessment and plan. And then in the plan too, we also include a spirometry referral if they were positive for the Canadian Lung Health. And this is a snapshot of what we also have a separate form for the Fagerstrom test. And this is a click box, and so it tallies up the boxes on their own, and then the score is at the bottom, and this can get saved in the patient's chart as well. This is a sample of what our follow-up visit looks like, and we track the type of encounter, so whether it was an in-person or telephone conversation, and then again, 6-month or 12-month follow-up for our outcomes. And then we assess, similar to what STOP asks for, information, so their status, and we track the status since the beginning of our program so that we can capture no changes, reduced, or are abstinent now. And then a little bit more details about their smoking status. So if they're still smoking daily, whether they're an occasional smoker, and if they're abstinent, we want to know whether it was within the last 7 days, the last 30 days, or 100 days, or 6 months. And then there's opportunity to just free text some discussion, assessment, and plan. So just looking at some of the questions that came up. So our EMRs, we use Acuro and PSS, and the templates are actually created by our data manager. I know PS, you can share it within the cloud. I'm not sure about Acuro, but we can look into that. And so lastly, we just wanted to share a little bit about our outcomes. And so this was last fiscal year, or the last 3 fiscal years. And the blue bars show the number of patients who have successfully quit at the 6-month mark. And then purple bars on top are the number of patients who were able to reduce. And as you can see, it's fairly stable and pretty consistent with the literature. And then 12 months, the number shifted a little bit lower, with, again, the blue bars being the number of patients who quit and the purple being the number who reduced. So with that, I'll hand it over to Eric to talk about our lung health program.
So one of the big, great, thank you, Christine. I hope you can hear me. So one of the big advantages of quitting smoking is to reduce the risk of developing lung disease and to improve lung health. So it just makes sense that smoking cessation is part of our lung health program. So lung health program is led by the pharmacists who are certified to provide respiratory education as well as spirometry. So we provide COPD and asthma education, puppet teaching, and spirometry. One thing that has been on the back of our mind for a long time is pulmonary rehab. But with the resources we have at this point, it's something that we are not able to provide, but we refer patients out if needed. But that's something that we would like to keep pursuing in the future, if possible. So for the Canadian Lung Health Test, this is something that we would administer to all the smokers who are referred to come for smoking cessation if they are 40 years of age and above, according to the CTS guidelines. So if they answer yes to any of the 5 questions, then the recommendation by the Canadian Society is to refer them for spirometry. So as Christine was showing you, the Canadian Lung Health Test is embedded in our initial smoking cessation template, it is to help us to remember to ask the patients those questions, as well as to standardize our quiz and our documentation. So usually the initial screening is done by the nurses or by the pharmacist, and then if they answer yes to any of the 5 questions, then a referral for spirometry will be done. And if they are sent to us, the pharmacist would usually go through that and then call the patient and confirm the Canadian Lung Health Test results. Because sometimes what happens is that the patient may say, yes, I cough regularly. However, when you ask the patient more specifically, then they would tell you, yeah, actually, I just clear my throat in the morning, every morning, and that's it for the rest of the day, and I'm okay. So in that case, then they may not really need to be screened with spirometry. So here is our flow for our spirometry referral. So if they are screening with the Canadian answer yes, so screen positive, then they will be referred for spirometry, either at our North York Family Health Team or elsewhere. And if they are coming to the Family Health Team, then the pharmacist would go ahead and give the patient a call to give them some pre-test instructions. And then we'll perform the test, the pre and post bronchodilator test. After the test, a report will be sent to the primary physician or nurse practitioner. And if the result is normal, it's recommended symptoms that the patient is showing, and definitely smoking cessation is the best thing they can do to improve lung health. And if the result is abnormal, then we'll suggest maybe further investigations and or referral to specialists like respirologists or respiratory therapists. So here is some statistics for Canadian Lung Health Test screening. It is for the year 2018 and 2019. So what is showing in the big pie chart is that there were 127 patients who were referred for, and among those, 58 were actually 40 years of age and above. So, they should be screened with Canadian Lung Health Test. But out of those 58, only 50 were actually screened. And for those who are screened, 23 were actually referred for spirometry because they were, 23 were screened positive, but only 13 were actually referred for spirometry. So as you can see, certainly room for improvement later on. So this is a intake template for spirometry. So at the top of the template, there's a spot for us to put down some demographic information and the reason for the test. And then, there is an area to put down a brief history for the smoking. And then in the middle is where we would check to make sure the patient is okay to proceed with the test. It is a list of where we are going to check if the patient has any relative contraindications to perform, and then a spot to put down any puffers they are on, and at the bottom would be the instructions that we'll provide to the patient on the day of the test. So for example, they should not be smoking within 1 hour of the test, and if they are on any puffers, they should withhold their puffers for a certain period of time before the test. So smoking history, as we discussed, contraindications, respiratory medications, and the instructions for spirometry. And so it's report. At the top, there is a place for listing the results on a table format, showing you the F1 and FEV1 over FVC. And in the middle is where the results are shown in a graphical format. And at the bottom, it is where the person who performed the spirometry will be able to provide some initial interpretation of the results. So we usually would interpret according to Thoracic Society guidelines, and if it is normal, then we'll just state it's normal. But if it is abnormal, then we'll say why it is abnormal according to the guidelines, and then recommend follow-up and maybe referral to a specialist. And this graph is just showing you the data of the spirometry we have at our family health team. So on average, it's usually about 10 to 20 spirometry that we do per year. So as you can see, it's not a high volume service that we are providing. In 2017, there was a spike, and that is how we have done some more service. Overall, it's not a high volume service, so we're just providing this service mostly to complement our smoking cessation program to allow the patients to be screened according to what the CTS guidelines are recommending if they are screened positive with the Canadian Lung Health Test. So with that, I'm going to pass you on to Rita to talk to you more about quality improvement.
Hello. Hi, everyone. Okay, so I'm the last pharmacist in line to talk to you guys today. So the last part of our presentation is really just to focus on lessons learned and quality improvement projects or ideas that we have in place for our program. So I guess to start off with, some of the lessons learned is really about our booking policies. In the beginning, we would receive a referral, and then we would jump on it and then call the patient, and we'd have the receptionist book them in. But we were finding that really a lot of people just wouldn't show up. We had a lot of no-shows. So over time, our booking policy has changed. And so now, even though we receive a referral, our physicians are aware, and the people who refer to our program are aware that we really expect that the patients initiate the first appointment. And the goal is really just to get the most motivated patients. And so we'll focus our efforts on those patients. In a sense, it has worked to really minimize our no-show rate and also our loss to follow-up rate. So we're spending time on the people who will benefit from it. We did try some group classes. I know CAMH does at the Nicotine Independence. We always hear about those group classes. So we did trial it back in 2013. It was just a one-time orientation class where people just came to learn about what were the options, what was nicotine dependence and withdrawal and all that kind of stuff. But we found that in our particular area, we had a very low rate of registration and enrollment. So that class, we got rid of that class. But there has been interest from patients and feedback from nurses and patients about interest for a maintenance group, or like people who have gone through the one-on-one counseling and they've quit, but they're interested in maybe doing a refresher or having ongoing support groups. So that may be something that we might have to look into. We're not sure how we would staff it or what content would be, but something that we may think about in the future. In 2014, we also tried to do kind of like a smoking cessation mail out. We had the program, we had built it, so we expected people to come, but we didn't really see that happening. So we kind of tried to dig for some patients on our own. We had our data miner, our data manager, go through our EMRs and try to identify people who were tobacco users in our EMR and also had COPD. Now, we all know, of course, the problem with accuracy and data in an EMR. So even though we had a list of people, like these were people on their EMR, they were listed as people as smokers, and they had COPD, we still felt the need to ensure that it was accurate. So we did have to get all of our physicians to review their own lists and then check off to see if, okay, yeah, contact this person, see if they're ready to quit smoking. So I think all of this, I mean, it was quite labor intensive. I think we had identified about 400 patients who met this criteria, and we ended up mailing about 300 mailouts. And then even then, we had a grand total of maybe 7 people who were willing to try to quit. And I think the end result of that was that only 2 people had quit. So we're not going to do that again either. So no mailouts for us. So essentially since 2014, as Christine had mentioned, we had decentralized, we expanded the program. So since then, and because we're a fairly large organization, and for whatever reason we have a very high turnover rate, there's ongoing orientation and onboarding. So as Christine has mentioned, we have trained over 50 nurses, pharmacists. So it's a lot of people that are now have a little bit of background in terms of smoking cessation. We also have done learning surveys in our own group to see what are our learning needs. We do in-house webinars, and motivational interviewing has been a big training factor for us. And I think as we move forward, we did have a big motivational interviewing blitz for our group when we first started the program, but we haven't had any ongoing training for that. So I think that that's something that's is recognized as a need for our group, because a lot of the new nurses don't have that experience and they don't have that exposure. So that may be something that we want to look into. And then, as Eric has mentioned, our COPD screening and our spirometry is built into our templates. The primary reason for that was because we just was finding that people were forgetting to do the screening. So that is a very big part of how we've needed to integrate. That's why our initial assessment looks so overwhelming. We needed to have all of those prompts built in for the nurses and the pharmacists to remember to do it. So the Canadian Lung Health Test is built in, the spirometry reminders, we have it in our initial now, we have it on our follow-up, and yet still we still struggle with getting that screening done, and people referred for spirometry. And I think when you talk to people like in asthma and COPD, I think spirometry use and access is a problem just in primary care. So this is something that we're looking to improve on. And I think it also requires ongoing reminders to the nurses and ongoing just in mind and kind of in your face type of reminders to remind people that they really should be doing the screening and getting people screened for COPD if they're smokers. Okay, and then finally, just to give you guys a bit of an idea of how do we get all of these outcomes, we're really fortunate to have the support of a data manager who helps us pull all of this data. And even with the support of a data manager and an EMR, there's still a lot of work that goes into the back where like chart reviews, and even though we have the list of people and we have a bit of basic demographics, it's still a person like myself who has to go through all of these charts to review and comb for all of the data that we want to capture. But we think that it's really important to have that data because it really helps to identify what are our program needs, who are the people that we're servicing, and if there's any gaps and in care that we can fill. And it's also good feedback for quality improvement, we think, because it gives us an idea of what our success rates are like, and if there's any other patient populations that we should be helping out here. So ideally, hopefully, the ultimate goal is to automate all of this outcome monitoring if we can do that. So that's still in the works, of course. Okay, and that's wraps this up. Oh, there's one question. Where do you get funding for all of the ongoing training? So the training that we expect people to go through is RNAO. So for the nurses, that's free of charge. That's paid for. We don't expect people to do the TEACH, which unfortunately now is a little bit more expensive now. When we first started out, it wasn't quite so prohibitive, and now it's a factor. But we do, the RNAO is not quite as intense, and some of the nurses were saying it wasn't quite enough. So now we also expect the new people to go through the fundamentals of the FTI course that's offered through the TEACH program, which is it's been free of charge for us. So I think it's kind of like a self-study. And then for the pharmacists, we've kind of all done the TEACH from a couple of years back, and we also have, if pharmacists come to us either with the Ontario Pharmacists Association training or any other training, we'll take that as well. Okay.
Thank you, Christine, Rita, and Eric. There's also one more question in the chat box. Jill asked if you have any plans to increase the programs in this area.
So unfortunately, just due to funding restrictions and the model of our family health team, at this time, we're not able to accept other programs. I did see a note here, though, that Black Creek CHC, also located in New York, does accept patients out in the community. So that's one option, I guess, for those patients. And then I just saw a question. Yeah, we can definitely share the medical directive. I think our contact emails are on the slide, so feel free to send an email and we can send you the templates too. We have the templates in a Word document too, so if anyone also has in-house IT support, you can share the Word documents with them, and then it can be uploaded into the various EMRs. We have one built for Organic Hero and PSS because it uses different shortcuts to allow people to tab through. So I think it's one of the first few slides with our email. I think Teach will send these slides out, and Victoria can confirm that.
Yes, we can send out your contact information as well as any other resources that you might be able to share, like the EMR documentation. So we'll just wait for a couple minutes and see if any of the attendees have any other additional questions. We'll just sit and wait for a couple of minutes. Okay, so that seems to be the end of our webinar. I'd like to thank Christine, Rita, and Eric for showcasing their successful smoking cessation and lung health program. Also, thank you to all of the attendees. The chat was very engaging, and this webinar has been recorded if you'd like to revisit any of the information that we've discussed today. We'll also be distributing the slides along with any of the resources that the North York Health team might be able to share with us. And we'll also include a link to the post-learning assessment, which will be needed to be completed by next week to receive a letter of completion. If you participated as a group, please email teach@camh.ca, teach@camh.ca, with a list of the names who attended with you today by 2 p.m. Our next webinar is scheduled for April in 2 months, and the topic being discussed will be commercial tobacco use in First Nations, Inuit, and Métis populations. Registration links will be opening soon. If you missed any portion of the webinar, please visit our website. Along with the recorded webinar, there will be a self-study option to complete a learning assessment before and after you view the recording. Please note that you will not be receiving a letter of completion for the self-study option. Thank you to everyone who attended, and thank you again to the North York Family Health team for presenting such a wonderful webinar. Thank you, everyone.
Thank you.